Good morning, ladies and gentlemen. I'd like to thank SAGE's leadership, the program committee chairs, and the Community Practice Task Force for the invitation to talk today to you about how to pitch new technology. I'm Mercedeh Baghai, a minimally invasive private practice surgeon from Torrance, California. I have no disclosures except that I do serve on my hospital's value analysis committee, and I use some of that experience for the subject matter on hand. So I'd like to start by saying that in order to stay current in surgery, we all have to adopt new technologies. Our training may have equipped us to critically evaluate the new technology, but adopting it into practice is much more complicated than just training for it. In the era of limited healthcare resources, asking for expensive, unproven technology is much harder than sometimes training on it. As Peter McWilliams said, if you're not actively involved in getting what you want, you don't really want it. This is more true today as for us surgeons than any other point in time. So the purpose of this talk over the next few minutes, 10 minutes or so, is to outline your role as a surgeon in the adoption of new technologies. I'll help you understand the process by which new technology gets introduced into a healthcare system and try and empower you with tools to navigate these pathways successfully to get what you want. As I was thinking about this subject, I reflected back on all the new procedures and products I've adopted over the years since being in practice. This list is in fact much longer than I expected, and undoubtedly some of these products were much easier to attain than some others. But the point I'm trying to make is that my practice has been constantly evolving without me actually realizing it, and this will for sure reflect your practice as well. So the process of adopting new surgical procedures and technology is in fact quite complicated. Unlike pharmaceuticals, which undergo a very stringent FDA oversight and lots of robust clinical trials prior to their rollout, surgical technology often lack long-term data upon introduction. So the onus falls on the surgeon to do a lot of the legwork. So your role as a surgeon champion is to evaluate the safety and the clinical outcomes and efficacy of the product. You're expected to train and gain proficiency outside of the OR setting. At some point, you're supposed to gain hospital support and buy-in and ensure financial viability of this procedure. And then go through your learning curve, obviously, with patient transparency, and eventually track your outcomes. So the surgeon's role in the adoption process, as I mentioned, has become more complicated. Yes, you have to evaluate, train, and master the techniques. But now you're expected to pitch it to the other stakeholders in the process, in the system. These will include people like the hospital administrators, the insurance payers, and obviously the patients themselves. The different stakeholders in the system will all have different motivations for adopting or rejecting the product. As a surgeon, your main focus is to assure patient safety and achieve great outcomes with low complication rates. The patients also concur they want a durable outcome result with minimal complications. The hospital administrator also wants a safe procedure, but they also wear a different hat. They need to optimize the system efficiency. They want to reduce redundancy. They have to contain costs and maintain a budget and maximize reimbursement. The payer, on the other hand, is motivated to just offer proven medical interventions and minimize costs, minimize waste, avoid experimentation, and maximize profit. So the different stakeholders all have different motivations. Your role as a champion is to figure out who makes the purchasing decisions in your hospital system. Now, for the duration of the talk, I will focus mostly on how to get the product into your hospital. I won't focus as much on the other stakeholders. But as far as who makes the purchasing decision, this will vary depending on where you practice. If you're practicing out of a small rural setting, small rural hospital, oftentimes the purchasing is done by the OR purchasing manager or director, or if it's a capital purchase, it may go up to the CFO or the CEO of the hospital. But in a larger healthcare system, this typically will fall on the shoulders of the Value Analysis Committee. Now, the Value Analysis Committee is comprised of a multidisciplinary group of people, often surgeon and nurse leaders and some administrators, even billing, contract, and liability specialists, supply chain personnel, all of which bring their area of expertise in the evaluation of new products. This broad perspective and insight during the evaluation process will often go much beyond just the cost of the technology. The goal of this committee, in one sentence, is how to get the best product for the right price for the system. Now, new technology pitching has many hurdles. The main thing is it's not easy. By definition, the new technology won't have a long track record of supportive data, and what data is available will be sparse and typically not robust. The cost is almost always an issue and typically prohibitive, and the reimbursement is often questionable. Typically, there may not even be a billable code, and most payers would likely consider the procedure experimental and avoid payment. And lastly, despite whatever clinical advantage you may predict the technology will afford your patients, the purchasing power does not lie with you. And in fact, it lies with administrators who have to, by nature of what they do, consider the above terms heavily in their decision-making process. So the Value Analysis Committee will evaluate products on 3 grounds. One is the clinical impact, the financial impact, and the operational impact of the rollout. To pitch a new product successfully, you need to understand and address these concerns in all 3 areas. From a clinical standpoint, it's important to differentiate between a product that is completely novel and new versus something that is a new modification of a competing product already in the system. Each one of these will have different hurdles to overcome. But no matter what, the product needs to fulfill an unmet clinical need. No one wants redundancy in the system anymore. The age of having 10 different hip prostheses on the shelves are long gone. Hospitals want to streamline their supply chain as much as possible. So any new product that's introduced outside of the existing contracts needs to fulfill a clinical void in the system. The committee always wants to see a track record of proven safety and efficacy. And as mentioned earlier, they recognize that the data may not be as robust as they would want, but they are willing to often rely on your personal experience or testimony of experts and thought leaders instead of randomized clinical trials. At the end of the day, the hospital wants a safe and effective product that fills a clinical void without raising potential liability. From a financial standpoint, they will most assuredly do a comparative cost analysis between the product you're pitching and any other existing product out there in the market or already in their inventory. This will include capital costs, disposable costs, operational and technical support that it may involve. They also would want to know if the product you're pitching is going to compete with a current contract. Or can it in fact be bundled into a contract, an already existing contract? This will in fact make a huge difference in the ease of adoption if your product can already be bundled into a contract. It's also important to understand the payer coverage. Is there a reimbursement code for the procedure, or is the expectation that it will be included into the DRG bundle payments? Obviously, if the procedure or the product is expensive and it's included in the DRG bundle payments, it will affect the bottom line and the financial viability of the procedure. They also will want to know the anticipated volume. If this is a costly procedure and you're expecting to do 2 cases a year, that's very different than if this turns into a procedure that is very soon adopted by every other surgeon in the department, and now all of a sudden 2 cases a year turns into 20 cases a week. The financial impact of that would be substantially different. And lastly, they may be interested to know of any marketing advantage that the technology you're pitching will give the institution in the community. And how, if any, is it going to impact potential referrals? At the end of the day, most hospitals will not object to a new technology as long as it doesn't lose money for the institution. Lastly, they will consider the operational impact the product will have on the system. The who, what, the where, and when are important. You want as many physician supporters as possible, and you want to anticipate any potential resistance or pushback your product may get from other folks within the system. The administration ultimately wants an easy and seamless conversion with universal adoption if possible. So now that you know what they're looking for, how do you go about submitting a request? So typically it starts with a form that's filled out by the purchasing manager, OR purchasing manager, with your help to provide the clinical information, and they will obtain all the financial costs, usually from the vendor or from the coding and billing department. Once this form is submitted, you're expected to then pitch to the committee or the CEO or the purchaser. So it's important to start by understanding who has the ultimate say in the purchasing process. Establish a good working relationship with the hospital and the OR administration. At the end of the day, if you work well with them, they will work with you. It's important to align your goals with the hospital's vision. Your pitch will be much easier as long as it's in line with what the hospital's vision for the future is. A good example of this is that if the hospital that you're working at is thinking of starting a foregut program, and it's just so happens that you are thinking of starting to offer the LINX procedure, well, that pitch will go a lot easier if you're asking your hospital administrator to overlook the high price of the product if it will easily fit into the clinical portfolio of the program they're envisioning to roll out. Lastly, make them understand what you want to achieve. Most of the people on the committee aren't clinicians, but they're open to hearing of clinical advantage a new product will render their patients, and they're willing to oftentimes fight for it. And lastly, spend the hospital resources responsibly. Be cost effective and don't be wasteful. If you are an expensive surgeon and waste a lot of products, your request will never be heard. Now, once you're a surgeon champion, the expectation is that you do your due diligence on the product. Be honest about your experience. If the product is new, no one expects you to have a lot of experience with it, but they want to know that you have critically evaluated the product and any data available. You've gone out of your way to talk to champions, to thought leaders and champions of the industry, and aren't just being driven by industry marketing. Focus on the clinical advantages the product offers and the limitations against the limitations of any other competitor out there. But also be prepared to talk about the potential complications and pitfalls that you foresee with the product. As my role on the VAC committee, I often ask this question about potential pitfalls and limitations because I want to make sure that the surgeon has done a critical evaluation and knows both the pros and the cons of what they are asking us for. And at the end, it bodes well if you offer to track your initial outcomes and share them later with the committee. It will also help if you work with your billing and coding department ahead of time and use the vendor resources you offer to establish whether or not there's a viable reimbursement for the procedure and how to code optimally. If the technology is not reimbursed, be forthright and suggest alternative solutions. Speak in a language your administration actually understands, potential. For example, length of stay or complication rates. If the product you're offering is going to reduce the length of stay significantly, that will by default increase the financial value of the procedure and will be a positive surrogate financially for the institution. Also, try and get as much support and interest from other surgeons as possible. It's a lot easier to turn down a request from a lone surgeon than it is to turn down a request signed by 10 other surgeons. And ultimately, the best strategy is to have a permanent voice at the table. Volunteer to serve on these committees, and that way you always will have your voice heard. Now, if you get rejected, which is often inevitable, don't give up. It's important not to be dissuaded by it. Go and reach out to the chair of the committee or the hospital CEO and see what more they need from you. Find out if the reason for the rejection was the fact that your product was competing with an existing contract. If that's the case, find that exclusion clause. No contract asks for 100% compliance, and you can often, once you read the fine print, find a way to introduce your novel competing product without upsetting any compliance parameters, especially if the product you're introducing will meet a void in the contract service line. A good example of this is, for example, if you want to get the ProGrip Paritex mesh in an institution with an otherwise barred or Ethicon contract, since those companies do not offer a self-gripping mesh, you may be able to use that exclusion clause in a way to get the product you're asking for. Also, don't be shy to ask the vendor of the new product to replace any existing product already paid for on the shelf. This is common courtesy, especially if you're meeting resistance from administration. Also, don't hesitate to ask for smaller favors. If the product you're asking for is expensive and you don't anticipate a high volume usage, ask for a consignment model, which is a pay-as-you-use program. That way, you'll never run the risk of something expiring on the shelf. Also, if the capital budget is not big enough and the capital purchase is too high, then ask for a lease of the technology instead of an outright purchase. Also, you can always ask for a short-term institutional trial to establish the value of the procedure within your institution before outright refusal or acceptance. So lastly, you need to decide whether or not how important this product is to your practice. How imperative is this technology, and do you have the patient volume to support it if you were to fight for it? Another factor to consider is how critical is this in you providing safe and effective care to your patients. This has become more of a reality in the last few years as financial constraints have forced hospitals to drop contracts and streamline their product lines. If you decide that the answer is yes, then you have a lot of ways you can force a hospital into obliging your request. Obviously, this is a lot easier if you and your group are not otherwise employed by the system and actually have some bargaining power. But I would always start with learning and knowing your financial value in the system. You may not know how much revenue you generate for the hospital, but I can guarantee you that the hospital administrators are fully aware of those numbers. And I'm not just talking about your surgical revenue, but also your downstream revenue you generate with your pre-op and post-op care. If that value is high, I can guarantee you they'll meet you halfway to keep you happy. Now, knowing these facts help you negotiate from a position of power, which makes this a very different kind of a discussion. Now, sometimes what we're fighting for is critical in providing safe patient care. In those situations, don't hesitate to leverage your elective case volume as a bargaining tool between competing hospitals. If they can't or won't get you what you need, you can always take your business elsewhere. Also, this may come across as an underhanded tactic, but don't hesitate to use your patients to bargain for you and for themselves. It's one thing if I, as a surgeon, ask for a specific product and I'm rejected. It's a completely different situation when the hospital CEO gets bombarded with emails from patients demanding for the same product. I can guarantee you those emails will be answered a lot faster than my email would ever be answered. In conclusion, a successful adoption of new technology requires a buy-in from multiple different stakeholders. The hospital administration and the value analysis committee members are not the enemy. They just have to wear a lot of different hats. So try and align your goals with theirs and present a product with a focus on the clinical advantages of the product, but with fiscal responsibility. Don't give up if turned down on the first try. Aim for smaller wins to get the product on the shelf and in your hands. Consider a short-term trial, a consignment model, or even a lease instead of a purchase. Ultimately, if patient safety is at stake, don't be afraid to leverage your value to the system to get what you need for your patient care. Thank you very much and have a nice